everyone, and thanks very much for joining us this evening. What I hope is going to be an insightful and informative discussion. My name is Wendy Jansen. I'm the Vice President for Colliers Project Leaders in Northern Ontario. And to begin, I'd like to take a moment to acknowledge the First Peoples on whose traditional territories we live and work. As we come together in this beautiful place, we pay respect to and acknowledge the land and with it certain truths. This sacred place, originally known as Anemki-Wedong, is now also the traditional territory of Fort William First Nation, signatories to the Robinson Superior Treaty. This land is the traditional land of the Anishinaabe and is where they and many other peoples have gathered. Also, we recognize that this land has been home to many Métis peoples. Colliers Project Leaders is committed to a relationship with First Nations, Métis, and Inuit peoples based on the principles of mutual trust, respect, reciprocity, and collaboration in the spirit of collaboration. We're honored to have this opportunity to bring people together this evening, and a special thank you to the Victoria Inn for hosting us tonight. This is an Indigenous, majority-owned facility, and we also thank the Michipikoten and the Nakachawinin First Nations for permitting us to use this space and to host this important conversation. So, someone asked me earlier, why is Colliers Project Leaders doing this? What is this about? And it's an honor to welcome you all to our very first ever Advancing Constructs event. There's significance to the name. These events are intended to facilitate forward-thinking, thought-provoking discussions and to spark further conversations that can help support steps towards positive advancement through our collective position as it relates to various constructs in our lives. In some cases, these will be societal constructs, and others they'll be jurisdictional, and in many included today, it will address both. Our team was inspired by the potential of this discussion and immediately sought out opportunities to extend our commitment beyond this event. So we're committed to supporting improved equity in Indigenous healthcare, and specifically in the Northern Ontario region. As a result, I'm pleased to announce we've partnered with the Northern Ontario School of Medicine University to offer the Colliers Project Leaders Indigenous Learners Award. This bursary is available by application for any Indigenous medical student entering their first year of medical studies at NOSM University and will be included in the January 2024 bursary submission cycle. So I'd like to invite Gord Wickham and Dr. Joseph LeBlanc to come forward, please. And we want to thank Dr. LeBlanc for accepting this giant check on behalf of the Northern Ontario School of Medicine University. Excited about that and being able to give back to the community in a meaningful way and inspire future doctors and medical professionals in the community. So again, our intention tonight is really to create a forum that facilitates dialogue about the challenges about accessing equitable healthcare in northern communities. And I'm going to quickly turn it over to Wes to lead us through some questions. Enjoy.
Thanks, Wendy. Really pleasure to be here tonight to facilitate the conversation. Little background on myself. I was previously the advisory engineer for Matawa Tribal Council for almost 17 years before joining Colliers about almost 3 years ago now. One of the big motivations for me to come here was my mentor, Gord Wickham, coming here and seeing his dedication to advancing the First Nation communities that are all around here and all around Canada, for that matter. So once again, it's great as well that we have the panel assembled here that we do. I think it just speaks to the need to have these conversations and dialogues. There's so many compounding issues in the remote communities that kind of are just looking for different alternative solutions to their everyday life. As part of my work at Matawa, I've assisted Nisga'a First Nation, who today enters their 10,492nd day of a boil water advisory It's the longest in Canada. We're almost going to be in 29 years here. There's a lot of issues in terms of how that kind of situation has unfolded. I think it speaks to a lot of different programming and the reason why it's so it's so prevalent in the First Nation communities around here. A lot of siloed program funding availability and not looking at whole communities as a whole. And I think that underlying theme is very applicable as well to healthcare. And knowing that Matawa, kind of their CEO, who I've worked with previously, has a tendency to go against the curve and get stuff done. So just like to acknowledge David Paul. But what I want to do in terms of our first question is kind of get a current status of each of our panelists' perspective in terms of the First Nations in the healthcare area that they are in. So Miranda, maybe I'll get you to comment first.
I appreciate being able to be here today to talk a little bit about the work that I do at the regional hospital at this point. I think my background in public health has prepared me to talk about the social and cultural determinants of health at this point and help to implement that in a primary and tertiary healthcare setting. So with that, I have previous experience working in an additional hospital. So when I was in the GTA, a little bit of my background as well is that I did grow up at Lake Helen First Nation, and then I did an undergrad at Lakehead University, and then that brought me to Toronto, where I was working with the Public Health Agency of Canada, with Carmen, I see in the crowd, with Indigenous programming. And while there, that's when I decided to go and do a PhD to be able to continue on in the work that I was doing to be able to help advance healthcare in these systems. And then with that, coming into to the hospital setting, where I initially worked at St. Michael's Hospital in Toronto, and then I did the research at Elizabeth Bruyere Hospital. And then that's quite a bit different than what we experience in the realities here in Thunder Bay, right? So if somebody needed to go to Elizabeth Bruyere, for example, and they didn't have the capacity at that point, they could just go to another hospital within Ottawa, right? Or if you're in Toronto, you could just go down Hospital Row and potentially go to another hospital there as well. So the realities that we have here, right, we're at the regional, where we have 69 out of the 133 First Nations in Ontario have the potential of coming in through the regional's doors. And then with that, 24 of those communities are also rural, are remote and isolated. So that makes it additional considerations that we need for transportation and everything into and out of the communities back home for home and community care. And then when you look at that sheer population, even within here in Thunder Bay, one of the research projects that I worked on was Our Health Counts with Dr. Janet Smiley, and then where you're looking at urban Indigenous numbers where they underestimated the amount of Indigenous people in Thunder Bay, and her estimates are more around 42,000. So you're looking at a significant population of people who potentially could be coming to the Thunder Bay Regional Hospital. So it is quite a bit, and a lot of the people have to come to Thunder Bay for acute care, potentially through the emergency room, tertiary, surgeries, everything like that, birthing, right? So if you're in a community, you have to be flown out to have your baby at the regional. So many people have to use the system out of necessity, right? But it doesn't necessarily align with worldviews. It doesn't, with past experiences, modes and models of care. Language is spoken, right? There's also a barrier there with potentially people may not be speaking English as their first language. So we have to consider that when people are coming into the regional and provide that care that is required for Indigenous populations. And that's why I'm there at this point with all of that background that I have with the Public Health Agency to help advance that work within the organization. Miigwech.
Thank you. And moving on to Jason, his life experience living in a remote northern community is really good to bring the perspective in terms of his life experience in terms of what he currently sees as the current status of healthcare for Indigenous people.
Okay, thank you very much. Thank you, everyone. So the Matawa communities, the The Matawa First Nation Management Corporation consists of 9 communities. And we had the Matawa Health Co-op start at around 2016. And it was created out of necessity in terms of trying to create additional services that would complement the health services that the communities were getting. So that's how it all began. A lot of our communities, I'd say maybe half of them are remote and the rest are semi-remote. With that, we see a lot of social determinants of health, as we would see with the other communities across the broader territory. So lack of proper housing is an issue in every single community. We have this brain drain in terms of human resources in our communities. Lack of health services, particularly in remote communities. Every community will either have one nursing station or a health center, and in very many cases, it is usually understaffed. And we have nurses and other community workers that are struggling and are overworked. And burnout is a very serious and real problem in, I would say, it's safe to say, in all of our communities. We also have people that have to travel out of their communities, whether it's temporary or permanently. Because of their need to access better health services. And very many people have come to us, and I know I've seen this actually myself as well, in terms of friends and family. Our emergency medical record system is all over the place, and I think you guys can understand it as well. It happens here, it happens up north. We probably have it worse than down here. Everybody has their own system in terms of their patient medical records. We have communities that are still using paper systems. And lastly, I think, in terms of our patients having to travel down to their communities, there are so many different levels and so many factors that hinder them in terms of making it to their appointments on time. And, a lot of times, many of these appointments end up in cancellation or postponements because of accommodation issues or weather, or even simply things as weather issues. So I'll leave it at that.
Just a short list there of concerns and issues causing problems. But does blend nicely into Joseph's turn to participate in terms of what he's seeing in terms of the current status and opportunity for First Nations people entering the profession.
Yeah, I think, I appreciate the introduction. I appreciate the words of the other panelists because, I think the challenge at a medical education or in healthcare education is to meet the innovation that's occurring in Indigenous communities. And the Matawa Co-op is a really good example of that, is to say that, the landscape of primary care is changing. The call for anti-racism competencies, the call for understanding the social determinants of health in a construct that reflects the systemic determinants of health is a challenge that the school is rising to meet. Working with learners to understand the systems that are behind what is presented in front of them, I think, is the challenge for educators, is to see that, a lot of this is intentional, right? The system is working to do what it was meant to do, which is to marginalize our communities, and, ultimately it's our responsibility to change that for the good. So, working with learners to succeed through a colonial institution, through a body of education that is oriented for certain populations is the challenge that I see sort of like emerging, and it's been there for a long time. Ultimately, we talk a lot about social accountability in medical education and what that means, but ultimately, I see it as this. Like accreditation is sort of the floor, right? It's the basic you need to have a medical school. As I say, you meet these accreditation standards, whereas social accountability is somewhere up here, right? And it's fluid. It changes as far as where the school is and where the orientation towards the communities they're meant to serve. So the act that created NOSM explicitly names rural, Indigenous, and Francophone communities, meaning that our challenge is to bridge with a competent curriculum and clinical experiences, cultural experiences that help to meet that social accountability mandate. And so, again, is to say that we have to find a way to do more, to support better, and to integrate what is happening at the community level. Traditional medicine is another thing that is we see more and more as a resurgence and acceptance, and the relationship with land and what that means for healing and well-being. And these are all concepts that are very far away from the competencies that come with the accreditation standards. So I guess I'll leave it at that for now.
No, thanks for bringing that up. And I myself was very fortunate. My mom was one of the firstborn, and my grandmother had 13 children. And I had a very lengthy relationship with my grandmother before she passed away, and she was in the traditional medicine and whatnot. And recently I was in Mishkagugumeen, and the gentleman who was driving us back and forth to the airport started talking to him, and he said, "Oh, we come back," and then ask a last name, and he's like, "Oh, Chisel." I'm like, "Oh, I know Chisel, Carla." And he's like, "Oh, it's my daughter." And I'm like, "This is crazy, right?" So then he started saying, "Oh, I know somebody else from so David Gordon." "Oh, that's my brother-in-law," right? So it's just like, "Whoa, well," and then start naming off people from Thunder Bay, and he's like, "Whoa," he goes, "I think everybody I know in Thunder Bay, right?" But it just kind of shows you that that there's only like the First Nation circle is very small there. So, but there are although we are unique, there are a lot of differences, obviously, between First Nation communities. Coming back to the social and structural determinants of health, maybe Jason can kind of expand upon that.
Okay, so just expanding on the lack of housing and overcrowding. So it not only creates conditions for higher rates of communicable diseases, but it also causes stress socially and with the family relationships. The high cost of food in the communities. So one of our communities doesn't even have a store. It's hard to maintain a proper diet. If you can't go and buy vegetables and fruit at your local grocery store, you can't abide by your treatment plan. That's been given to you. Never mind prevention. We don't have enough health infrastructure in our communities. It is very, very hard to find any space for mental health counseling. And in many communities, you will see a mental health counselor driving around in a truck with their client providing counseling services. It's not just a one-off incident that happened. It happens in every community, unfortunately. We don't have any programming space, no storage spaces, or even accommodations for visiting professionals or mental health counselors or any other type of service providers. So this results in a day trip by service providers. So you will have a charter go in the morning. They do their work, they do their business, they see their clients, they meet up with the leadership or other local community workers, and they'll have to fly home at night because it's construction season. It's summertime, it's high time. There aren't enough accommodation spaces in the community, so the contractors have reserved the local hotel for 3 or 4 months completely booked. That results in higher costs in terms of delivering programs as well and services, because you have to charter there and back. You can't just hop in on a morning scheduled flight and fly back that evening. It just doesn't work like that. We also have some communities that are on boil water advisories, and as a result, there are health effects because of that. We have wounds that are not properly healing, and the other issue is antibiotic immunity. I remember back in the 70s, antibiotics were prescribed for every single thing. It's because, a lot of times I think there were no other types of medicines that were available to try and deal with the local illnesses. And as a result, antibiotics, the yellow powder, I don't know how many times that was given to me as a child. Almost every single visit I made to the community. It's not at the fault of the CHRs that were there or the nurses. It's just that's all that they had. Yeah, I talked a little bit about the having to leave the community for health care and for long-term care and lack of housing. Yeah, so we don't have any real long-term care services in our communities, right? And there's a need for palliative support as well. Especially when we are having issues with consistent nursing services when that's a challenge, So it's there's a lot going on in our communities, and it's more especially our elders, and we're trying to figure out some solutions in terms of how we can support them.
Thanks for that perspective. We're actually working with Atawapiskat now on a proposed elders facility. And when we went up to have a conversation with the chief, one of the former chiefs, his comment was, a lot of these residential school survivors are reaching near end of life now, and they're having to be taken away from their community again at end of life, their sunset years. So it's kind of being placed in that similar situation with not having the supports to help them at that time. So he even said, when my friends leave, when I don't see them again until we're burying them, which, kind of hits pretty hard. So maybe Miranda, if you can comment in that area in terms of what you're seeing at the hospital in terms of those impacts.
I feel like your lived experience actually lends a lot, and I'm thankful that you're here for that, to be able to provide that from a remote perspective. I think from my community itself is not remote. We certainly have similar issues as well, but definitely compounded when we have in communities that far in the north. And then we have urban Indigenous, right, who also face similar barriers here within the city itself, when it even comes to transportation, right, and when helping somebody leave a hotel, for example, how they're going to transfer from the hotel to the hospital. If they have an infectious disease, how does that happen, right? So it's barriers that we're consistently met with. And that leads to the social determinant of health of access to care, right? So you have to take a look at it from a more of a holistic perspective, particularly within the hospital and especially in Northwestern Ontario. So in doing so, what we try to do is reach out to our partners and who we have available in the community to help provide more of a wraparound care, and to recognize, that these barriers exist. We're within the system that wasn't essentially made for us. Barriers are created by the systems themselves. So we are really strong advocates for equitable, safe care closer to home, right? And to be able to not have people leave their communities if possible, and to be able to help assist in that sense, and working with partners to help achieve that, and to help mitigate some of those barriers and social determinants of health that affect health outcomes. And then we also have to address, within hospital systems themselves, right? We acknowledge that it's not necessarily a system that was created for Indigenous peoples. And even within, we have examples where they're quite well known, where there are incidences within hospitals that have been a result of other social determinants of health, where you have culture, right? And race, and how that gets impacted. Childhood experiences may not be at forefront of mind when you're in a primary healthcare setting, right? How adverse childhood experiences may affect health later on down the road or currently. So with that, I think we have to acknowledge some of those things that do happen within those systems and help mitigate that and help come up with some creative solutions, I guess, sometimes to some of those barriers, working with partners so that we can lessen the amount of like structural determinants, right? You were speaking about structural determinants, about incidences of racism, incidents of discrimination, and then how that's all affected by colonization overall.
Yeah, kind of along those lines, Joseph, maybe you can elaborate a little more on that point.
Yeah, I think it's important, to understand that, there's both interpersonal and structural elements of racism, right? And some of that is hard to sort of identify. And you spoke about some, public incidents that have happened, and Joyce Echequan and the Justice for Joyce movement that followed really highlighted not only that interpersonal element of the comments and the treatment that occurred, and her bravery to share that with the world, I think left a gift and a legacy where, we can start to talk about that in a different way, because we know these stories happen, and that witnessing that occurred in the live stream and others, was really, I think, impactful. So, then we saw the structural elements come out where, the Premier of Quebec said there is no such thing as racism within our healthcare system. The professionals who undertook that, disciplinary actions are not adequate. And, as we look to see, what does it mean to either legislate or hold accountable those acts of interpersonal racism, there is a lot of use of the structural element as a shield to hide that in a lot of ways, right? Is to say that, we can throw our hands up and say, oh, the system is broken. As individuals, you work the system, you make up that system, right? And one of the elements that really, I think, didn't fit well with me coming to medical education. My background is in forest conservation, and I work with communities around food sovereignty and food system development, and those actions that sort of intersected with industrial forest management and wellness, right? Because, we know in the community that our wellness is directly connected to the wellness of a broader community of non-human relations, and the land and the foods that are there or not there in the case of where there aren't market access to healthy foods. A lot of that, like I said before, is intentional, right? And as you look to sort of dismantle and understand, it is a very troubling reality, right? It's been known for a very long time that the cost of food in remote First Nations and now, creeping into rural sites is increasing with inflation. And there's very little intervention to address that, right? We have legislation in Ontario that regulates the resale, what you can resell concert tickets for, right? This came after the whole Tragically Hip thing. But we don't have that for food. Right? And why is it that we don't have the will to do that? Is to say that, food is actually a common good or a public good in that construct, to say that, and we see that at the community level, people making innovations with the ADI program, for example, or the child nutrition program, and making sure that their clients access a good food box, or these kinds of innovations, like I say, that are happening, at the community level, are really important, right? And really are that sort of intersection of how do we address, yes, the system is broken, was built this way, however you look at it from whichever perspective, but it's the choices we make as individuals that then lead to positive or negative outcomes in somebody's life. So let me leave it there.
Thanks. In looking at, the long, we're still kind of in this sort of recovery post-pandemic, but I think one thing we did see again was the resiliency of our First Nation communities in terms of their ability to kind of really put their own policies and procedures and protocols in place and keeping it in a halt. However, it did come at a cost, obviously, when they had to, basically suspend all medical care because they weren't able to get access to the communities. We do have a couple of projects right now where We're just actually finished retrofitting the dental facilities to meet code. But you look at how long has it been? So all those people who live in the communities on a long-going basis haven't been able to access something as simple as dental care, right? And you know, how complicated does that get for people with comorbidities? It kind of makes you wonder, how are they ever going to get by? How were they getting by up till now when they didn't have the ability to have the professional spaces, you know, from a confidentiality standpoint even, and all those things that make people feel welcome and safe in the provision of healthcare. Some of the things that kind of were impacting that were jurisdictional in terms of their ability to do that. So maybe I'll get Joseph to comment first on some of the jurisdictional boundaries and issues that he sees in his role.
Yeah, I spoke of that like need to meet Indigenous innovation, and some of that is that, you know, navigation of this jurisdictional divide that has affected so many lives, right? It is that passing the buck between the federal and provincial jurisdictions. And, you know, in reality, right, a lot of those lines are false, right? Like you talked about the unseen Indigenous population in Thunder Bay that Dr. Smiley was able to capture more accurately. And that's because of the fluidity of our communities within these territories, right? Traditionally, people traveled great distances to, you know, share medicines or knowledge or to, you know, learn. And, you know, ultimately that false division, right, has created these gaps that really, again, I think both sides of the crown hide behind, right, is to say, okay, well, that's a federal thing, this is a provincial thing. You look at, you know, natural resource management, for example, in our food systems, right, we're managing those for the extraction of wealth for foreign interests, right? We're managing for mines, we're managing for forestry, but we're not managing for the well-being and long-term viability and sustainability of the people who are going to be there forever and have been there forever. The other side I see a lot is the distinction between like a municipal government and band councils, right? Like municipalities are able to make bylaws and make decisions that don't have to be vetted by the minister of anything, and whereas many BCRs are you know, not respected by colonial entities. It has a really strong impact on health human resource recruitment and retention because, you know, hospitals are generally in cities and towns, and those cities and towns are able to work with community foundations and industry and others to bring incentive packages for physicians to recruit, to provide a house, to, you know, and Jason spoke of the challenges of just getting a hotel for visiting health professionals, whereas, you know, neighboring municipalities will be, you know, offering a job for their trailing spouse and offering free housing for a year and loans and all of this kind of stuff that really comes from that fulsome like agency as a community that municipalities have. And, you know, for all of the challenges that rural municipalities have, I don't want to, you know, disrespect that, but it is a different jurisdictional capacity than to be able to pull together, you know, like these packages and foundations and other things to support that. So we have to really think about what that means when we're recruiting Indigenous health professionals and training as physicians. Like, we know alumnus that have had a really hard time establishing a family medicine practice on reserve. And that has everything to do with the jurisdictional challenge that's there. It has to do with their ability to, you know, have enough patients for their, yes, but that's not it fully, right? It has everything to do with their ability to build a clinic, to hire nurses to work with them, to create a work environment that is akin to what you would see in a municipal setting.
Yeah, thanks. Jason, maybe I'll get you to elaborate a little more on how Matawas see what current jurisdictional issues you see in your role at Matawa. Although I know, like I said, David Paul tends to just kind of do his thing and deal with that after, but.
Yeah. I guess to the way our communities are situated, some of our communities are right on the boundary lines of different service catchment areas, as well as political treaty organizations. So that kind of sometimes leads to some confusion. And sometimes different service providers will receive different amounts of funding, whether it's because they're getting federal funding or provincial funding. You know, that creates recruitment issues between service areas, wage parity when it comes to nursing. But it goes beyond, you know, just nurses. It also applies to mental health counselors and such. You know, once they find out that they're being offered another job somewhere maybe closer to a southern center with more higher pay, of course they're going to go, right? So those types of things arise. We also have some of our service providers, or rather our communities, who don't have multi-year funding agreements. And this leads to headaches in terms of trying to create community health plans, in terms of trying to address health issues. They also have to then have to apply every year annually for funding. And sometimes we think, okay, well, why is that such a big deal, right? Where we fail to understand is that, you know, a simple act of writing a report can be quite challenging for many communities, when many administrators don't have access to or even don't have time for training when it comes to administration duties or management training. Again, I talked about the lack of accommodations in the communities. Health team visits in the communities occur, but there is no place for them to stay, so they end up coming in just for a few hours. The other thing is the continuity of care is lacking because of a high turnover of local staff in the communities. I talked about burnout earlier. We don't have sufficient resources, not just funding-wise, but just resources in general in terms of having people come in, provide training for administrative duties or programming activities. You know, that impacts our communities a lot. We also have jurisdictional clashes, I guess, at the micro level, you know, between different service providers. Everyone right now is kind of still a bit protective of their work, you know, their sources of funding, you know, all their little tricks of the trade that they all practice to be able to try and secure additional funding for themselves. You know, that happens in our communities and amongst the different service providers. We also have different communities, community members who have to travel to different townships, I guess, to be able to access health services, just because there's a border there between the service providers, where they are more familiar with and more comfortable with a certain town, you know, that might be on the other side of that border, where they have a whole ton of family living that can support them. They're sent to that other town where they don't know anybody, and you know, have to unfortunately live there at times and just not have that support. Having said all this, there is an example, I guess, that was established for, you know, we have a model for future coordination of services, and this was brought about during COVID time, during time of COVID, right? It kind of brought the service providers together to be able to coordinate what everyone was going to do in terms of on reserve or the off-reserve population, right? And established clear roles and responsibilities after a lot of discussion. And, we saw a lot of our own health staff at the health co-op travel into these communities to provide vaccinations and, providing PPEs. And the Northwest Health Unit provided those vaccinations. We do have issues with the public health units or any other public provincially funded agencies. There are still some hesitancies for them to travel into our communities. I cannot provide you a clear explanation as to why that is the case, but we do have those types of issues that still occur.
Thanks. And Miranda, I know in our previous conversations you indicated you see some jurisdictional issues in your role. Maybe you can speak to some of those.
Jurisdictional issues are, I always say this, the bane of my existence because it's a constant advocacy, right? To try to convince the federal departments to, provide a certain level of care within a provincially funded system. But then it's also because we're a hospital known as a provincially funded system, then a lot of times with Indigenous peoples within that system, they say, well, Indigenous peoples are under the federal mandate, right? So it's a lot of passing the buck, as you had said, or like pointing fingers about like, no, it's you pay for this, no, you pay for that. So I'm being in that system, I'm sort of in between that, right? So I'm trying to advocate for both people to come to the table, or both organizations, both governments to come to the table to be able to work that in a better way. As you were mentioning too, like proposal-based funding, like even the system itself, I think creates breeds competition among everybody because you're competing for the same pots of money, right? And like as us in a provincially funded system, like when we put in an application for funding, we're mindful that we don't want to be taking it away from other organizations who may be able to use it in a different sense, right? So we're always trying to like walk a tightrope about like where do we find jurisdictional challenges and all of that. So it's also very difficult sometimes to find reliable, continual funding sources, as you were saying, like multi-level, multi-year agreements, right? And generally it's more or less like, we'll give it to you for 1 year. Let's do a pilot, that kind of piece. And then when you do get that multi-level, then you're always concerned, is this going to have a sunset or is this going to end within that? And then like even just with terminology, right? Sometimes like there's a misconception that Indigenous health is purely federally mandated. But then when you look at the definitions of like the little boxes that they put us into, right? Where Indigenous, First Nations, Métis, Inuit, where the federal mandate is actually for First Nations status and Inuit, right? And then you have people who may be caught within those systems where they have lost status because of colonization or for various reasons, and they deserve status, but they don't necessarily have those check marks checked off, right? To say that they are status and they are funded federally in that sense too. Gender-based discrimination within the Indian Act, right? Creates that as well. Métis people, right? Métis peoples are not included in that either too. So urban Indigenous, sometimes like we come across people who are urban Indigenous in the cities, but because their status card is expired, right, they're no longer able to use that federal source of funding, and oftentimes they're not able to go back home to a community or somewhere that they could renew a status card, for example. So there's multiple like definitions, and like they put us into these little areas and systems, and then we like, again, it's the innovation, the creativity that we have to come and meet that with.
Yeah, and even on like, I mean, you look at the impact of a single year funding agreement in terms of your retention of your staff, because obviously in today more than ever, the economic realities make it pretty easy to say like, well, I don't have any conditions on this employment offer of a year, and then I got to be worried in 10 years into this or 10 months into this position, am I going to be out of job again in 2 months? I know we're running a little bit longer than planned. But I think
my watch is listening to me because it just came up with Reddit for Ontario provincial funding. That's not funny.
Big Brother's listening.
They are. Ontario Public Service.
I think Jason kind of alluded to the fact earlier, some of the stresses of working. I know in my own role, my previous position at Matawa, it does get very difficult in at times just because you end up they're not clients, you know, these are your friends and in some cases your family. So it's a lot more emotionally, you get a lot more emotionally involved in terms of providing your service, and you know, whether it's relatives or whatnot, or even good friends that you know you're in 20 years in with. And I think that aspect is really one of the biggest ones that I had to cope with when I was working at Matawa for the duration I did before I left. But in terms of your own role, what do you find the most challenging aspects of your day-to-day experience, and how does that impact your general well-being? And maybe Miranda, I'll get your comment on that.
Yeah, that's like it exactly. Like being at the regional hospital where friends and family come in all the time, right? So it's like having to do a job, but then also ensuring that your friends and family are all well taken care of, as well as a whole entire community of people, right? So it's that's what is definitely challenging. And I think overall too, some of it is also encouraging people to like unlearn, I guess, and unlearn what they think they know about Indigenous peoples. Helping people understand, you know, that not just like you were talking about over in like interpersonal racism, right? And that does occur, like it definitely does, but systems can also be racist, right? So to talk about like what is making up a system can potentially impact a person in that way too. So I myself, and I know people and members of the staff that I work with also hear daily stories, right? About, and not just individuals, but also like about incidences of implicit biases, which is like essentially like negative attitudes that you don't necessarily are consciously aware of, right? So a lot of times it's, it can be very overt, can be very interpersonal, but a lot of times it's related to things that you may think about other people that are not necessarily true. And you may not even recognize that you're thinking that in some way too. So I think it's very tiring, I think, sometimes to constantly be trying to convince people of your humanity, right? So you're in a role where you're like, we are people, we are a community. We deserve equitable care and safe care just as everybody else does. And it's very difficult to do so, like on behalf of yourself and your family and a community and all of that, and as well as other equity deserving groups, right, that are along with that too. So it's not, like I always say this, it's not necessarily my job, it's my life, right? So it sort of blends together. I can't just like leave my job at 5 p.m. and be no longer an Indigenous person, right? And no longer an Anishinaabe. But like, yeah, so it's, I find that what I think is the most difficult. So I think that's what mostly impacts my well-being, I think, overall. But I think I'm very thankful for the community that surrounds me and like the people who actually helped me get into this role are very mindful and help take care of me in that sense. And even just this Friday, we're doing full moon ceremony, so I can talk about these things and get their support in that way too.
Maybe I'll ask Joseph's perspective now on how he deals with, obviously, he's got a pretty wide perspective on how this is, and what do you think in terms of what do you find the most challenging in your daily role?
You know, some of that I think that Miranda was sharing right around, you know, you can't sort of like separate your role and purpose in community from your job, right? And, you know, some of that I think is highlighted in that, you know, I'm the first Indigenous associate dean at the medical school, but I'm also one of the first Northern Ontario-born leaders at the medical school. And, you know, I was an undergrad at Lakehead when they built that building, and, you know, those kinds of things. Like, I never thought I'd walk in those halls as a student or as anything, but, you know, like, the responsibility that carries that means like I have no intention of going anywhere. Like I'm not going to go retire back wherever I came from or go move on to be, you know, at another school in that way. I have every intention of staying here and affecting change for our future generations, for our relations and our communities. So, you know, there is a different, I think, weight of that, you know, you have to find the balance. And, you know, honestly, I really, really enjoy our learners. Like I really enjoy, you know, the seeing them, you know, succeed, seeing them overcome some of these challenges. I was looking at some stats because we created an equity strategy 2 years ago that has an anti-racist approach and focuses both on interpersonal and systemic changes. We had 72 Indigenous graduates to date. In our current residency and undergrad program, there are 69 Indigenous peoples, right? And, you know, that I see as a really important shift, right? Is to say, you know, we were able to go from what I say is like an EDI approach of saying there are 2 designated seats to a target of 20% of our class. We're not there yet, but we're getting closer. You know, there's 15% of our class currently first years and second years. And, you know, these are people who are going to go and work in these innovative situations. They're going to become leaders in hospitals throughout the region. And for many of them, I hear the same thing, that vested interest. They're not trying to go get a residency elsewhere. They're trying to fight against that. They're trying to get a residency close to home. They're trying to work in a career trajectory that like is tied to that vested interest and that responsibility. And that's not to dismiss the role that, you know, people coming to the region can play as well, right? Is to like new entrants to Canada, international medical graduates are playing a really important role across the north. And, you know, like I said, like managing my own wellness through this is about rooting in understanding that people are making change. There is something positive that comes of this, and just to try to like sleep at night too. Yeah.
Yeah. Well, I think even just seeing our panel here, you can kind of see that we're definitely moving in a positive direction with the positions that everybody has here. I worked at Matawa, as I said, for a long period of time, and my own experience was you were never really off, because I mean you're on vacation and you still get called, but I mean those are your friends, so you got to respond, and that's a reality. But there also is a lot of gratitude in terms of resolving those issues, because you know there's going to be another one coming right after it. But I don't know, Jason, if there's any what do you find most challenging in your day-to-day?
I guess it's the just the overall challenges in terms of trying to improve health outcomes in our communities. You know, the trying to improve the that continuity of care. You know, the healthcare system and the healthcare outcomes. A lot of that work requires a lot of effort, and we realize that we can't do it alone. We need our partners and other service providers to be able to help us manage our caseloads. And a lot of times, the willingness is there, and with service providers and organizations, and other times they are not. And it takes a lot of energy and effort away from other duties that we should be doing to be able to just to advocate, with these service providers to, join the team, get with it. Let's get to work, together, working for our communities. The other thing too we've been doing is, we've been working towards incorporating traditional healing and cultural practices into a holistic approach within the Matawa Health Co-op, but it's also not been without its challenges. We have to continuously advocate with funding agencies for a scope of these services to be maintained in such a way that is effective for our communities, and that they continue to fit the original vision of how our traditional medicines and our cultural practices can continue to serve us and not be restricted by funding criteria. So even things like that take a lot of effort, time, and energy. We have so many things that are going on in our communities, and a lot of times unfortunately, we can't work proactively. There are times when we do, but a lot of times, and more especially when it comes at the community level, a lot of time is spent trying to address social issues and just continuously operating in crisis mode. And that gets quite draining for our community workers. So we try to support our community workers, give them that, those debriefing sessions that they need, the training that they need, as well as even just encouragement, going up into the communities and just showing support for the communities during crisis. It's little things like that are so important. So that's what we try to focus on.
Thanks for that. I think obviously we've identified a whole number of issues here that we're seeing, but in terms of opportunities for improvement, in terms of positive systemic change in the healthcare system, I'm wondering, Jason, if you can maybe comment on what are your thoughts in that regard in terms of where you see potential.
Okay, so I think the First Nations running their own healthcare systems is, simply put, probably the best first step, but that requires proper resourcing. That's needed to be able to create an efficient and effective programming and systems for our communities. The inclusion of our traditional knowledge and culture to improve the health outcomes for our people is very important. That's one of the main messages that we get from our elders at the health co-op is we can't forget our culture, and to bring back, our traditional medicines that, were very, very helpful within their own lives and their own communities. So we are looking to incorporate these traditional medicines as part of our primary care, to be able to maybe one day work with our diabetes wound care nurses, because we do have medicines that can assist in terms of healing our community people, as well as incorporating our culture into our land-based programs and our mental health, and that includes spiritual counseling as well. So we have traditional healers that we utilize in our communities. We would like to use more of them in terms of coming into our communities. We do use them, but not as much as we would like to. They would like to come into our communities more often than they are, because they see the need is so great. Fiber optics is not available in our communities, all our communities just yet, but it is going into our communities, but at a very slow rate right now. I see a lot of opportunities to improve supplemental virtual services when it comes to mental health counseling, and to be able to access specialists like psychologists and psychotherapists, psychiatrists, as well as enhancing virtual primary health care in terms of accessing more primary health care providers for our communities. At the health co-op, we have doctors, nurses, diabetes nurses, wound care specialists, foot care services going into our communities. And because, the need's been so great in terms of trying to at least provide health services that will meet the needs of our communities, that demand is so great. We've grown from 2 people from 2018 to 65 people now. And, that just kind of goes to show that I think, we need to create our own solutions when it comes to providing services for our communities, but we can't do it alone. We're not there to provide these services, create these services, and provide services alone. We need everybody's help to be able to provide, a level of care that's equitable, essentially.
Thanks. And Miranda, what would you think? What do you think are the most, I guess, potential sources or avenues for opportunity in your role?
Yeah, I guess, well, a great first step is to see all of us here and talking about this and having these conversations with folks here today. But like even like within the hospital itself, like very specifically, like we're recognizing that a lot of change needs to occur, and we've really like built up the frontline staff that are available for patients that are coming into the hospital. We're fortunate now to have 4 Indigenous care coordinators who work with inpatients, and then we have 5 Indigenous patient navigators who work with outpatients in the certain clinics that they would come into, for example, like complex diabetes care, the emergency department where we know that we need additional support for sure. We've recently were able to hire a cultural safety educator who is staff facing, so to be able to help and work with staff to, like just today we had a lunch and learn that was set up by our patient and family cares unit, I guess we should say, but where they had the cultural safety educator come in and talk about sacred bundles and what you may see on a patient, right, potentially, whether or not like it's a medicine bundle attached to their clothing, or whether they wear it around their neck, or they may come in with a feather, or they may come with other sacred items within that bundle, and like and how you treat those, and what it may be not what you expect to see, but this is what you would potentially see within that. So it's also not only like the front line, like I was saying, but it's also for the staff. But then we also have very like active community partnerships at the moment, where we work with St. Joseph's Care Group and Mashkiki and Grand Council Treaty 3, Delico and Matawa Education Care Center and DFC and NNEC. So we know, like you were saying, like we can't do it alone. So like we really reach out to those partnerships, and I'm very thankful to be able to work within, like even my title alone, like Indigenous collaboration, right? Like that means so much to me, because I think that's what's needed, where we need to be able to collaborate and creatively solve these things like with that. And then coming on, like it was very helpful to know that even within at the hospital itself, they have a strategic pillar of their strategic plan for equity, diversity, and inclusion, as well as like Indigenous collaboration, where there are a number of like initiatives under there that we're actually actively working towards, like steering committees for ETI, TRC's call to action, and all of that. Cultural safety training is part of that. We're currently doing a policy and procedure review and working with actually Dr. Janet Smiley again to help us like take an anti-Indigenous racism and anti-hate lens to some of our policies and procedures that exist. Physical environment walkthroughs. How many do I have there? I don't even know. But experience sharing for understanding and respect. And then ultimately, again, what we were talking about earlier, which is Indigenous recruitment and addressing some of those barriers when it comes to recruiting people into these places.
Those are great initiatives. I wasn't aware of some of the other ones, but that's really good, really promising. Joseph, maybe if we could go back to you, and where do you see current opportunities to, I guess, expand on the success that you've had so far?
Sure. So, I think there's a tremendous opportunity in the transition from the Northern Ontario School of Medicine to NOSM University. As of April 1st of last year, we're Canada's first medical university. That means something new for this region. And the goal for the institution is to not compete, but to collaborate with existing institutions and programs, and to add health professionals education to that. Coupled with the creation of the university was also the expansion. So nearly a doubling of the programs from the start of the school, which means that there's a new opportunity there to build on the alumnus that have graduated, the lessons learned in that process, but also to focus that education, and some of that is in residency. Really proud to be able to collaborate with Matawa Health Co-op on the Remote First Nations residency stream. It's very unique in Canada. It's a family medicine program that also includes 6 months of community and cultural teachings that are led by elders. I think that in large part there's an opportunity for that to be a part of the future. So in a couple of weeks there's a retreat talking about the future of family medicine in Northern Ontario. Some of that needs to be the +1 specialties that lead to greater health equity outcomes for the region, and in empowering, that to occur closer to home, and in some ways relieving some of the flow of patients to places like Thunder Bay, because as we've heard, it's very challenging to go to a city far away from home, and we've heard over and over, you come into this world outside of the community and you leave this world outside of the community, and both death and birth are this sort of like mysterious thing for youth and children to not see that process occur and to see that happening, in a traditional manner. So not just, the medical program, but other programs that are needed is what we're exploring. Not going to create, a nursing program, because there are nursing programs throughout Northern Ontario. Like I said, we're not here to compete, we're here to collaborate and to add. Micro-credentials, I think, are a really, really good opportunity to collaborate. More and more, there are navigators being hired at hospitals, right? Is there an opportunity to collaborate on some training that sort of brings that anti-racist lens, brings the advocacy and conflict resolution skills that are needed in that position to this institution and then to the communities that we serve? So I see a tremendous amount of opportunity there. When the school started, it was really about meeting those accreditation standards. It was about finding the right doctors to supervise the students and then get to that place. Now that it's been 18 years, there are a number of alumnus out there practicing in Indigenous clinical sites that didn't exist before, right? That didn't exist in 2005 when the school was created. So how do we now weave those environments, that knowledge and that experience into our clinical teaching opportunities, right? And so some of that is about going beyond what we call 106, which is the cultural immersion, and working with Indigenous clinical settings to build clinical rotations into undergraduate and residency experiences. So I see that as a really bright future. And to also comment, I think it's interesting to note that the positions that we're in now didn't exist 5 years ago. So the more and more that happens, and the more and more leaders that exist for us to collaborate with, like there are now 4 Indigenous deans across the 17 medical schools in Canada. I'd like to see 17 of them in some way or more, but ultimately, it's nice to have our table filling out a little bit more and more people to collaborate with it that actually get it. So,
Well, that's really promising, and you can even see. I mean, I from my water lens, you can see where we have external operators coming into the community, getting embedded in there, and then once they're accepted by the community, it really kind of helps facilitate discussion. So you can see on a medical perspective how beneficial that'll be from an improvement of the provision of medical services. So that's really good and promising. That was we wanted to end on, obviously, opportunity here that we see, but we also wanted to know if anybody had any questions regarding any content or anything. So maybe we'll open the floor. Both Lindsay and Jordan have microphones if anybody has any questions.
Thank you very much. I learned a lot, and I appreciate the discussion. You talked, Jason, you mentioned, self-governed healthcare delivery. I know of one example in Canada that there's a BC First Nations Health Authority. Is there any movement in Northern Ontario that you're aware of communities starting to look at ways to move forward on self-governed healthcare?
Yes. So the organization, the Snibeski Nation, I think maybe they're going into their 4th year now in terms of health transformation. So they've been looking at different models in BC as well as Alaska, and trying to find a model that they can refer to in terms of their own health transformation. My role at the Matawa Health Co-op came about because the chiefs of the Matawa First Nations said, hey, we want to do our own work. We want to consult with our own communities in terms of how we want to move with transforming health systems for our communities. So for the last year and a half, our focus has been traveling into the communities and talking with the women, youth, elders, the leadership, community health workers in terms of how they envision health services that would work for them, you know, at the community level, but also at the Matawa level, which then ultimately would connect to the broader health transformation system with non-territory. It's going to be a long process. We're moving along, but yeah, there is work that's happening, but it took BC 20 years to do it, and that was, you know, that was a long time, so I don't know how long that will take us.
I am wondering if any of you have any thoughts on the distinction-based healthcare that the federal government is working on, the legislation?
I've been at those tables, and you know, overall they you know, are taking this sort of approach of like a very unique kind of definition of consulting. They sort of like round people up virtually and then tell us what they're doing, and then, you know, it's scheduled for an hour, and at 40 minutes they're like, oh, no questions? Okay, good. Okay, we'll leave. But, you know, I do think there is some value to that like conversation, and to support, you know, what Jason was speaking of is a long-term transition. It's not a light switch that they're going to hit and say, okay, now, you know, and in part is to say they're sort of playing right into that jurisdictional divide that we talked about before. Like, you can't ignore the fact that, I forget how many communities you said would come to Thunder Bay Regional Hospital, right? Like, that is a reality. That's where the surgeons are going to be. That's where the specialist care is going to be. So the distinctions-based legislation actually has to represent each distinction-based group, right? And part of the hope and advocacy that we've been doing at those tables is to actually put some legislation in place that criminalizes what happened to Joyce Echequan, right? To put that type of hate-based harm into the criminal code is not all that different of a stretch, right? Like, if you you know, undertake graffiti that includes hate, it's an elevated crime. And similarly, if you provide that level of negligent care or harmful acts, then it should also be coupled with that type of support. So I think that it's on the participants to keep pushing the Crown to think about more than just legislating for this distinction, as to say in Indigenous settings, but also to take a look at, you know, the point that I was saying before is that it's very fluid, and people are going to go into provincially funded hospitals, and people are going to go into federally funded health centers, and as individuals, they have a right to do that, right? So I thank you for the question.
This question is for Miranda. I'm just wondering, when people are hired at Thunder Bay Regional, if they do some onboarding training in terms of even the geography of the North. Sometimes I get baffled. I'm up in the North and I'm trying to transfer a patient, and they're asking me, have you done a HCT? I'm like, I'm in the middle of nowhere. I don't have even anything here. I'm just using my ears, my hands. So I'm just hoping that maybe, I don't know if you have anything that is available out there in terms of training, culture, geography, who the people in the North are, because we come from so many different backgrounds. And I think that would really be helpful.
Yeah, and that's exactly what we're working on. So that recently has been implemented, where we, it's myself actually who will go into the orientation sessions, who will speak to students and residents that come into the hospital as well as, but then even people who are onboarding for an administrative role, for example, then yeah, that we have the opportunity to be able to speak to those people as well. I know even when we're talking to external stakeholders too, we really try to make that point of like, this is the geography, right? It's not just as simple as you think where you may have that situation in Toronto where you can just go down to the next town, right? So we're really trying to get that point across where that the numbers are often underestimated, right? But then we also have this very, very vast geography. And then we also have Indigenous people who are not a monolith, right? So like as you were touching on where like distinctions based has to be for each of those distinctions, right? So we have to ensure too that people are aware that some people may request traditional care, some people may request spiritual care from a multi-faith perspective. And yeah, we're just not making assumptions of what people may want at that time. But that is something that we're working on very particularly right now and very targeted to be able to get that messaging across for sure. Thank you for your question.
Can I add to that?
Go ahead.
So, yeah, I think the concept of like cultural safety training is really important, like a baseline sort of understanding. So if you looked at this as like a laddered learning approach, right, or, you know, a staircase is to say, making sure that everybody coming in the door has a similar sort of exposure to the basic understanding and then building competencies upon that. And that was an important part of the first couple of years of our equity strategy was to start with the incoming undergraduate class. And this year's NOSM class is the first medical students in Canada to be required to take an Indigenous cultural safety training before they start. So it's not something that's done as part of the course when they submit their first aid and the other things before they start. They submit one of 3 Indigenous cultural safety trainings that we worked with our community relations to identify as being relevant. But that's not the end of it. It really is that fostering of developing competence across those environments. So I really appreciate the question because we hear this all the time, you know, wanting CPD or somebody else to help with that training and to understand that, like, if you're discharging somebody home to a rural or remote First Nation that doesn't have food access in the way that you'd expect it in an urban setting, you meet with the hospital dietitian and they say, okay, go home and eat this diet. If that's completely contextually inappropriate, it's a very ineffective thing to do. So, I think building on that competence and working together to do that, I think it's not something that we sort of just stop and say, okay, it's done.
I would just say that in my experience with the Safe Drinking Water Act as well as the current proposed legislation, it's kind of a similar experience where there's definitely a discrepancy in what the perceived term of consultative development is in terms of being handed a piece of legislation and provide comment on it as opposed to cooperatively work together in order to develop it. But it's no different in many aspects, right? But again, very promising to hear, though, and hearing everybody's perspective here tonight. It looks very positive going forward, and even in terms of the success that all of you have had. So I want to thank all of you for joining our discussion here tonight. And maybe if we could get a round of applause for our panelists here. Thank you. Thanks for coming out and listening to us tonight. I myself, as indicated, I'm from Akwesasne, but I would like to acknowledge the work that Colliers is doing in terms of in light of reconciliation. We do have First Nation Indigenous cultural training that is provided to every employee. And I myself, you learn a little bit of stuff that you don't know, just given the, I say, a lack of continuity in terms of your own education. And Gord, I have to thank Gord for that. Gord was a major, precipitant of being able to do that at Colliers and providing that perspective for all our employees. It's still kind of interesting just because it's, my own life experience. My parents both attended day schools, and that's only one generation away. And, you talk to people in terms of what that what that impact had on my parents, but some people are just shocked that, you know, that was not that long ago. It's only one generation. So you can see how it takes a long time to address those issues that have, you know, kind of precipitated as a result of that. And that's only one aspect. But when you look at, you know, the multitude of issues that First Nation people face, whether it be, you know, clean drinking water, you know, overcrowding in their houses, you know, the lack of viable infrastructure, all of those things kind of are just, it just spawns additional issues. The lack of proper O&M funding for 20 years on all those assets that have been kind of there since maybe early 1990s. It's major capital investments required, but we keep kind of using the same systems without making any change, and you're not going to see any real change until you kind of address, as opposed to slapping legislation down and thinking that that's the solution without thinking out, or even doing some consultation with the communities and find out, you know, what are their interests, how do they want to develop. Thank you for joining us, and look forward to some positive outcomes here in terms of First Nations healthcare.